billing, because news today that in Kalbarri, the GP there, the Kalbarri doctor's surgery, will close on June 25, and they're saying that they can't stay afloat since shifting to a fully bulk billed model. Not sustainable. Will we see more of it? Let's go to Simon Torvaldsen. He's the AMA Council of General Practice Chair. G'day, Simon.
Hi, Jamie. Hi, listeners.
Is this are we going to start to see more of this? Do you fear this will be a familiar story?
I fear that it might be. I mean, we hope not, but there are pressures on general practice, and the difficulty is that forced bulk billing or essentially asking people to run businesses that are unsustainable isn't going to be the answer. And I think everyone needs to be reminded that when Medicare first started in the 1980s, the rebate was set at 85% of the AMA schedule fee. I mean, it was all agreed on. Everyone thought that was fair. 85% was made up for the fact that the paperwork was simplified, and nearly everyone was bulk billed. I mean, a lot of GPs don't have any philosophical objections to bulk billing as such. We've just got to make sure that the staff can be paid. But over time, that 85% has dropped now down to around 40%. So essentially the rebate in real terms is halved, and it just makes it essentially unsustainable.
Yeah, so the rebate hasn't kept pace with the costs.
No. And the other problem we have is that medicine has become so much more complicated. When Medicare was designed, a 5 to 10 minute consultation was quite common, but now things are so complicated that it takes time to sort out problems, and people are getting older and have more complicated problems, and we need to spend the time with people. And the way the Medicare rebates are worked out is the longer the consult, the less the rebate per minute. So, and also that the rebate is the same whether you spend 6 minutes with someone on 19 minutes, and when you get to the next level where it's 20 minutes plus, the rebate per time actually drops significantly. Yeah. So the longer you spend with someone, the worse it gets. And so it's a double whammy. The rebate's been reduced over time, but also we're needing to spend longer with people to give the care that they require, and it really makes it very difficult.
I suppose you don't want to disincentivise GPs from spending the amount of time they need with their patients too.
No, exactly. And if people need that kind of care, that's what keeps them well and out of hospital. And the additional problem we have, Jamie, is that no doctor goes into any field of medicine in order not to be able to give the care that people need. So what we're effectively doing with low rebates, and especially if bulk billing is enforced on doctors, is we're really saying either you earn a very low income or you have to take shortcuts and see more patients per hour and not give the level of care that you know people need. And neither of these things is going to attract young doctors to want to be GPs.
That's a good point. What are we seeing in terms of numbers of GPs coming through, Simon?
Look, I think in fairness, the government would say, look, our training courses are well subscribed and we are getting people trained and so forth. The problem is that a lot of those GPs nowadays are not working full-time anymore. They're doing other things to supplement their GP work, and one of my colleagues who did a workforce analysis for the health department here in WA a few years back worked out it takes somewhere like 2 to 2.5 new doctors to replace one older doctor like myself. And so even though we're training the numbers, it's not necessarily translating into the number of hours and the number of patients that need to be seen.
Yeah, the output,
and we're also losing doctors at an increased rate because people are saying, look, I'm fed up with this, I'm going to retire early, or increasingly GPs have other options and they just find other things to do.
So how are different surgeries navigating this, I suppose, Simon, with the reality of what the rebate is? Are they offering, are there gap payments? Are they not bulk billing at all? How's it playing out?
I think it's playing out differently in different areas, and it's different for everyone. And one of my fears is that, in fact, we end up with what I would call a two-tier system, so that because there are certainly areas and people in circumstances where they can't afford large gap payments, and so we may end up with a system where there's government subsidised sort of bulk billing clinics that see patients for a relatively short period of time and are not able to give the care that people need, or else have great difficulty in attracting doctors because the remuneration is not adequate.
Yeah.
And so those areas where people can't afford care, despite the government saying it's all free, actually get poorer care and end up with worse health outcomes. Whereas those who can afford it, there are other doctors who will say, look, I'm sorry, you're just going to have to pay a gap, and this is what it costs, and people will pay those gaps, and if we can afford it, that's not unreasonable. But my concern is that it's actually disadvantaging those people who need the care most and who can least afford it.
Yeah, so it's not as simple as...
That's not the way Medicare was set up.
Yeah, it's not as simple as holding up the Medicare card saying, this is all you need before an election. You know, the devil in the detail here shows that health outcomes could actually be poorer for it.
No, exactly. And the AMA, in fact, has put to government a very clear and very simple blueprint for fixing all of this at relatively modest cost. And unfortunately, as to date, despite the fact that government acknowledges it and acknowledges the problem, they're not actually doing very much about it. And it really wouldn't cost a lot to fix. They're willing to put enormous amounts of money into hospitals and all sorts of things, and, submarines and what have you. But this fixing primary health care in Australia is actually not particularly difficult or expensive. It needs a relatively small investment.
Will this be exacerbated, do you think, in the regions as well? So I'm just noticing here this situation in Kalbarri, which is a bit of a disaster for those there, or even just for tourists as well who might need a GP if something happens. But, there was another closure in Northampton that was going back to last July. Is that where the impact of this is being felt first?
I think to some extent it's universal, Jamie, but the thing is that in the country, firstly, often the practices are smaller, so the economics of running a smaller practice are more problematic. And secondly, it's got an enormous impact. So if you have the only GP in a country town that is no longer there, that's no services at all. Whereas if that same doctor in the city retires or stops practicing, at least there'll be someone somewhere around that will be an alternative. But in some of these areas, people have to drive a long way to get the alternative. So it's got a very large impact.
All right. I appreciate your time today, Simon. Thanks for the insight.
You're very welcome.
Simon Torvaldsen there, who's the AMA Council of General Practice Chair.